to the podium.
So we have as panelists Dr. Richard van Hillesberg from Netherlands, Utrecht, Dr. Koji Nakada from Kawamura, Dr. Ji-Young Park from Korea, and Steve Mellon, who's a mentor of survival, Tabitha Dream Foundation. Okay. So let's begin. I would like to ask some comments from Gianluca first, because Gianluca conducted a very nice study in 2013 in Italy. It was called Charta Scaligero, in which he, me, and Giovanni and several other friends, we discussed about follow-up. And surprisingly, many of our colleagues didn't think the patient should be followed by us. And it was the Italians and the Brazilians in the one and the others in the other. And Teresa told about feeling abandoned because the family doctors doesn't know. Please, Gianluca, make a comment on that.
Yes, it was interesting to note that the 4 reasons on which we based the decision to make it not evident, because it is not evident, but we stated that the follow-up should be done where for audit and for nutritional reasons, but the most important was called pastoral by Bill Allum. Giovanni, do you remember that Bill Allum called pastoral one of the 4 reasons? Because the patient would like to be followed. Even there is no scientific evidence that following the patient improves survival, and maybe it is also, when there was no effective chemotherapy, it was an anticipation of death sentence. But at that time, we decided to make a sentence, a statement that follow-up should be made also for pastoral reasons. It was interesting.
Thank you very much. So before opening for the floor, I want to hear, Richard, in your country, what about follow-up with the surgeon himself in those patients, please?
Follow-up is done on a regular basis. So during the first 5 years following surgery, first year quite intensive, also with the aid of dietitians and physiotherapists in order to rehabilitate after this kind of intense treatment the patient has received. But not with regular CT scans, for example. We do blood tests, and we do looking for all the factors that were appointed. And well, I think this is extremely important because you see that patient needs a network in order to rehabilitate after this kind of intense change of the gastrointestinal tract, especially after a total gastrectomy.
Nice. So, please, the word is open for our colleagues from the table and from the floor. Please, those who want to participate.
Yes, I remembered in the Charter Scaligero a big discussion, but at the end, probably we were just a dreamer because nowadays for me it's very important to follow up, and we put that the only way is CT scan. Especially at the beginning. So nowadays we can have many weapons. So I think that many people change the idea about follow-up in many countries. I know that follow-up is expensive, so we have to think that in Italy our system is a sort of system that is not collapsed yet, but pay for everybody. So I don't know.
Okay, please.
Yeah, hi. I want to make a few comments about my quality of life right now. I'm 53 years old, and I am as happy as I've ever been in my entire life. And it's amazing to say that because of the things that I've gone through. And when people see the life that I live now and the things that I do, they see I'm loved by my wife and my children. I'm supported by friends that I've had since I was as young as 5 years old that stuck with me through the whole process, the good and the bad. And for me to stand here, just to be as happy as I am and to be able to travel around the world and help spread that positivity and that hope is what I'm here for. During COVID, I didn't slow down. It didn't stop me. I actually hopped on maybe over 100 flights, all for fun, nothing for business. And it was great because no one was on the planes. But it was, but I took advantage of every opportunity. So life can be really, really, really good if you allow it to be. And even though I could go on and on about the challenges that I have to experience continually, I'm still continuing challenges, but it's nothing compared to what I've been through. So I'm very blessed. So thank you for listening.
Yes, please.
Hi, my name is Hans. I'm an 18-year gastric cancer survivor, and I lived for 7 years with a partial gastrectomy, and then eventually had a total gastrectomy with a jejunal interposition. I didn't even know what a jejunum was prior to that surgery, but apparently I have one. But my quality of life is so much better with no stomach, no esophagus than it was with a partial stomach. I have no problems with reflux. I can eat more, just in general. But what I wanted to mention was when we're talking about quality of life, a lot of it seems reactive. When I had a chance to go and visit the Catharina Hospital in Eindhoven in the Netherlands, they do a great job of sort of before the surgery, kind of prepping people. In fact, the culinary team there does a great job of showing people how to prepare meals, what it's going to be like with no stomach, eating in smaller quantities, eating more mindfully. So I just thought that might be a good takeaway for a lot of practitioners to think about, instead of only in a reactive way, maybe before the surgery, to kind of prep them for a little more of, so you don't have that shock of waking up with this, with this redacted system, maybe ahead of time preparing your patients for the upcoming challenges.
Nice. Dr. Nakada, please. In Japan, do you have a specific questionnaire, something to evaluate quality of life?
We have some simple checklist for post-gastric patient and a detailed questionnaire. So the name of the questionnaire is PEGASUS Post-Gastrectomy Syndrome Assessment Scale, which evaluate the patient's symptoms, living status, and quality of life. And we have national data for this questionnaire. So if a patient in front of us reply for the questionnaire, I can compare the condition of the patient with national data who received the same type of gastrectomy. So we can understand which part is wrong with this patient and how we can support this patient.
What about you, Dr. Park?
Hello, I'm Jiyeon Park, and for my short introduction, I'm a GI surgeon in Korea, and then I'm also a survivor of the cancer. I received the total gastrectomy when I was 28, when I was in the medical students. So it was really a great honor to participate as a panelist in this session. And in Korea, we have a questionnaire that we can evaluate the patient's quality of life. So we just developed and validated that kind of questions, and then we got a quite good results. So we are applying that quality of life the questionnaire to the patients. And as a patient, I was really worried about the recurrence. So even though I went through the total gastrectomy, I don't have any regret that why I have to do the total gastrectomy. So past 10 years, it was really past 10 years, and I still free from the worry about the recurrence. But as a surgeon, I really care about that they are eating after gastrectomy. So I want to save more stomach for the patient. So it's a little bit awkward, but yeah. So I have a question to the survivors that which one is the most important thing for your quality of life, like eating disorder or cramping of your abdomen, sudden abdominal cramping, or the weight loss or recurrence of the cancer. So which one is the most important thing?
Improved?
the important thing to
Oh.
affect your quality
For
of life.
quality
Yeah,
of
yeah.
life, well, I'm a little bit of a different case because I have a genetic mutation, so I'm at risk for multiple cancers. So the issue of recurrence, I've never actually felt really terrified, except in those initial years, about the recurrence, because I don't know why. I felt that once I hit my 5 years, that was good, and then at 10 years, I was great. I was more worried about other things, other cancers. I think for me, because I went through such a difficult time mentally and emotionally, trying to learn who this new person was. I was a completely new person because I couldn't eat what I used to eat. So I had to learn right from the beginning, like how to eat differently. And I remember one of my doctors, because I kept asking him, like, this is ridiculous, I keep losing weight. And he said, and he was a lovely doctor who's since passed away, he said, darling, you have to realize you do not work like everybody else. So I always kept that in mind, but I think for me, it is so important that we are looked at holistically, and I know Katie mentioned this earlier, because I think quality of life is not just about nutrition, and it's not just about weight loss, or it's everything. It is about trying to come to terms with the fact that we've dealt with a very complex disease, as you know, and the complications from it don't ever go away. Not really. I mean, we get better at dealing with them, but so for me, it's about the most important thing is about being able to accept and being able to learn and keep learning, and working on my emotional and my mental self.
May I ask a question? My question is for Yuichi-san. Thank you for sharing your story. I want to know, how are you connected or connecting to other survivors in Japan, and how are you finding your psychosocial support needs here? Thank you.
In Japan, there are many patients gastrectomy, and many patients I heard information, more information, and but that's all.
So you find the patients online, or how do you meet the other patients?
Same hospital, and same community,
Thank you.
Thank you.
In Italy also there is an important association, Paolo knows very well, which is Vivere senza stomaco si può, meaning life without stomach, it is possible. And they are very connected by Facebook.
I think they are connected. I think they are connected now from Italy.
Claudia, ci sei?
I don't know.
So actually in Japan, there is not such strong organization except Kibo Kai, which is organized by Mr. Todoroki. But there is since long time, there is some small booklet delivered for the gastrectomized patients, reporting their own experience and so on. That's called Alpha Club, but it's a limited organization. They're not so common in Japan. But like Mr. Inaba, many patients recover from cancer and long-term survivor. But I think that at the moment, not only in Japan, especially in Japan or in Eastern countries, we emphasize the importance of spiritual care for end-of-life stage patient. But hearing all you talk, I think you all have a kind of spiritual pain you had, and even you may have at the moment. So all doctors should take care a little bit about the spiritual pain of patients who underwent gastrectomy. So Terezia's case is a little bit special because the Lynch-Hughes syndrome is cancers. You experienced many cancers, but anyway, not only that kind of diseases, but every cancer patient continue to have that kind of either small or large, the fear and spiritual pain.
I think it's an important, very important remark. We looked into the quality of life data, and so health-related, mental, also functional, in the Logica trial. That was total gastrectomy versus laparoscopic versus open, and distal gastrectomy included. And we found in all the patient anxiety, for example, is higher after this kind of surgery, but especially total versus distal. So if you have an organ-preserving approach, all those patients perform better, not only from a functional point of view, but also from the anxiety point of view. So I would make a strong play to really look into the quality of life and not only focus on survival, which is important, of course, but also look in all the mental and health-related quality of life of these patients.
Yes, and one thing I was impressed when I attended my gut feeling last November was, yes, including a specialist in psychology, and yes, we are concerned about our patients' survival, and but nowadays younger patients survive. Then one important issue is childbearing. So it is. I would like to encourage our patients, once you're overcome, contact OB/GY specialist, because yes, it's so great moment. We save patient, and she delivered a baby next life. So this is now more and more possible, and we should pay more attention and also information sharing. That's I want to share with you.
Nice. I want to make a comment on what Professor Sasako told, because almost 40 years ago, when we were in Paris, we presented our thesis to Paris University, and together with us, there was a priest who was also a doctor, and he became eventually the Bishop of Lyon in France. And his thesis was spirituality and science. So this is very important, because many times we surgeons, we are very skeptical, very cold, and we have to keep in mind that this for the patients must be very, very important. Please, more questions from the floor. Yes. So I'll make one question to Richard. We have now a tragedy going on in the world, and this is a message for all of you, because we have opinion makers here. Is the obesity. The cause of many cancers, Teresa cited in her speech. So what about the obese patients in gastrectomy in your country, especially junction cancer?
I agree. This is, I think, one of the main causes of this junctional disease, as well as esophageal cancer in the distal part. So that I think is extremely difficult to cure. Of course, you need prevention, you need information, but it's not only that. I think it's a general way of our life that we are influenced by the food industry, and so it's very difficult to cope with that. But it's an important problem.
I know, you know, because our department is also treating obesity surgery, and we receive many women operated on with breast cancer, sent by the gynecologist, the surgeon who operated on the breast, to make, because 70% are obese. So asking us to do bariatric surgery, because the rate of recurrence will go down. So this is very important, before the cancer and after the cancer. This is a message for you. Please, more questions.
Yes, I'm going to lead us back to the quality of life evaluation. Ms. Tiano, is there such a similar type of process in Canada where you're based?
Yes, I know that. I mean, whenever we were going through, when I was going through treatment, there was always, whenever I went in for my sessions, there was always the forms to fill out as to how you were doing emotionally, physically, where your, what your sort of energy level was at, where you were at, with your eating habits. They even asked financial questions if you needed that type of help, which was great. The only thing I found was I didn't really feel that it was followed up upon. And so that would be that continues to be one of the things that in our organization, as I'm sure in your organization, we try to focus on. And again, long-term follow-up. These patients aren't just patients for like 2 years or 3 years or 5 years. But definitely, yes, there is a process during treatment.
Yeah, so our, just to comment on that, so in Canada currently we do collect something called the ESAS score, so Edmonton Symptom Assessment Score. So all of our patients that come into the oncology clinic, they do receive these scores, and these are upheld by the Canadian CCO, so Cancer Care Ontario. So currently we are doing quality of life evaluations because people recognize how important these are. And actually my gut feeling is currently partnering with Dr. Coburn's group in Sunnybrook to look at financial toxicity and other quality of life indicators. So definitely a lot more to come from Canada.
Dr. Norero from Chile.
Yes, very nice lectures. I have a question maybe, I think it's for Teresa. I wanted to ask about your experience with your advocacy group about impacting clinical guidelines or the policymakers, maybe the Ministry of Health or your institutions, especially thinking about higher costs, evaluation or treatments. I'm thinking like genetic testing or immunotherapy, which is not, supported by some healthcare systems.
So, in Canada, our first mission was actually to make people aware about stomach cancer. There was no organization when we were diagnosed, so Katie and I started it together. The way that we impact is what we have done is, in a number of occasions we have been part of, we are the patient advocacy group that provides input to governmental bodies with respect to drugs that could be made available to patients. and that's called CADITH, and I can't even remember the full length of it. So our input, and we do that by going out and, surveying all our community, has actually enabled 4 different drugs to gain accessibility for patients. And so with gastric cancer, there really weren't that many options. We still don't have that many options. They're way better than they used to be. But we're very proud of that work because it has put forward, the fact that now patients have accessibility to drugs that they would never have accessibility to. We also work with researchers and have written white papers with respect to genetic testing. That's very close to my heart. But in general, we partner with many research teams in Canada so that these papers are put forward to be able to then, change, hopefully, the guidelines. And we're also working on 3 big research projects that deal with all that type of work in the next 5 years.
Excellent.
Thank you. So we're rounding the top of the hour, but I would like to ask Steve Millen from USA about quality of life evaluations that he received and the follow-up that he received after his treatment.
Nothing. I know there was nothing. So I'm learning a lot here about what people are getting now, but I didn't get anything. So my life is pretty good right now, though. But I could say that. But no one told me that I'd have to have 5 dilations on my esophagus because of a stricture. They wouldn't tell me that my gallbladder was going to be gangrene and have to have that removed. They didn't tell me I'd have to have intestinal resection 1.5 years ago because of all this. So maybe I'm glad they didn't tell me all that. But my quality of life is phenomenal because I just take what comes to me. And but I don't know, it's been hard, but it's been good.
Thank you. Are there any other questions or comments for our speakers and panelists before we close the session?
One last comment. Please pay attention to the response of the surgery, the difference between men and women. This is quite different. Please pay attention to that. Thank you.
Thank you, everybody, for attending. I hope that you enjoy the rest of your sessions, and thank you.